and welcome to our third day of this 10-day CRISP revision series. So in the last 2 days, hope you all enjoyed reading maternal medicine module. And now today is the third day, and let's take up the another module, which is very, very important one, that is management of labor and delivery. So let's start with fresh enthusiasm. So here comes the first slide. So what all we will be dealing with today? See, these we have given according to the weightage in exams. All know, and we all often are perplexed by the CTGs. Okay, so CTG interpretation and escalation of intrapartum or routine labor care according to CTG interpretation. This holds quite a lot of weightage in exams. Then comes medical conditions in labor. Now, they are asking integrated questions. So it's very important to integrate things, that is correlating the maternal medicine module and the labor and delivery module. So many questions nowadays are being asked with medical conditions in labor. Or you can also say intrapartum care in existing medical conditions. Then, very, very important topic, that is preterm labor, PPROM, and cerclage. Followed by in intrapartum care, we have got a section that is stages of labor, delay in first and second stage of labor, followed by induction, labor analgesia, how to choose between intermittent auscultation or CTG, and then the new guideline, the brand new guideline, reduced fetal movements. So all these topics are very, very important. So let's start. So in the first hour, we will have a rapid walk through the following topics: place of birth, the stages of labor, the medical conditions in labor, then labor analgesia, fetal monitoring, whether to do intermittent auscultation or continuous CTG, a bit about reduced fetal movements, and followed by preterm labor and PPROM. So the most important topics we will be dealing with in the first hour. So let's start. Now coming first of all to the basic things, that is place of birth and stages of labor. We all know that in UK they use 4 birth settings, that is home, freestanding midwifery unit, alongside midwifery unit, that is the one which is attached to the hospital, and then followed by obstetric unit, which is a consultant led unit, we can say. So the ladies can be characterized, any pregnant lady on booking can be categorized as either nulliparous or multiparous, and then they can be categorized as low risk or high risk. So if any lady is low risk multiparous, then they can be safely allowed to deliver at home or midwifery led unit, depending on her choice. Means a talk is done, she is explained about the benefits and risks and all the facilities, and then she can be free to decide whether she wishes to deliver at home or midwifery led unit. What is good in these places as compared to obstetric unit is that they face fewer interventions, and as such there is no significant increase in adverse neonatal outcomes. Now let's come to low risk nulliparous ladies. In low risk nulliparous women, usually they are advised to birth in midwifery led unit, which may be freestanding or alongside. Why? Because in midwifery led unit, the rate of interventions will be less as compared to obstetric led unit, as well as spontaneous delivery rate will be higher. Whereas at home, there can be a small increased risk in the rate of serious neonatal outcomes. How much? Like for example, 9 per 1,000. Okay. So if they birth in midwifery led unit or obstetric unit, then the rate of adverse outcomes will be less. But if they birth at home, then the rate of serious neonatal outcome, adverse neonatal outcomes, increases to 9 per 1,000. That is, there is a difference of about 4 between consultant-led unit and, that is, obstetric unit and home. So Due to this reason, low-risk nulliparous women are usually advised to birth at midwifery-led units. However, it depends on their choice. All the benefits and risks are explained and then they are free to decide. However, if any risk factor is there, depending on maternal or fetal or previous history, then they are strongly advised to birth in obstetric-led units. Okay? So this is in brief regarding the place of birth. Now, regarding the stage. The labor is divided into first, second, and third stage mainly. The first stage is again divided into latent phase and established phase. Okay, so latent phase is called as whenever the contractions are not very regular. And also on per vaginal examination, the findings reveal less than 4 centimeter cervical dilatation and there are not much changes. Whereas in established labor, the contractions become regular and cervical dilatation has advanced to 4 centimeter or more. So this 4 centimeter is the threshold, remember, to differentiate between latent and established labor. Another pearl point here is diagnose delay only from the established phase forward. Okay. Established phase only after the established phase, that is after 4 centimeter. Then if the progress is slowing down, that is we are examining after 4 hours and progress is less than 2 centimeter, then only label it as delay. Okay. So this is a pearl point. Please do remember this. Then what happens when she lands up in established labor? Start giving her continuous 1:1 midwifery care. In second stage, now this was up till first stage of labor. What about second stage? Second stage starts as soon as she becomes fully dilated and lasts up till birth of the baby. Second stage again is divided into passive and active. Now, when it is called as passive and when it is called as active, that is decided on her urge to push. When she is fully dilated, but she is not having any urge to push, that is, baby is not visible on the perineum and she is not having involuntary contractions or involuntary urge of pushing, then it is called as passive. As soon as the baby is visible on the perineum and or involuntary pushing begins, then it is called as active stage of labor. Okay. So this is regarding second stage. Again, there might be delay in first stage. There might be delay in second stage. We will look at that later. Then comes the third stage. So in third stage, that lasts between delivery of the baby and delivery of the placenta. Active management is usually offered unless and until the lady refuses. What are the components of active management of third stage of labor or AMTSL? Giving oxytocin, 10 units IM. Deferred cord clamping, delayed cord clamping allows blood to be transferred to the fetus, and then controlled cord traction. Now this has got what advantage over physiological third stage? What is physiological third stage? When we are not administering these kinds of things. We are not administering any uterotonics and we leave the lady. We don't do any interventions like delayed cord clamping or controlled cord traction. We allow the placenta to deliver by itself, but this is the risk that the chances of PPH are slightly more than active management of third stage of labor. In fact, not slightly, but the difference is like 13 and 30. Okay. So this is the mainly the stages of labor, first, second, and third. Now, in every stage, what you have to keep doing is you have to encourage mobilizing. Why? Because supine position as such is not recommended. We don't advise the lady to be in supine position during whole of labor because it delays. Okay. So always encourage mobilizing the lady throughout the labor. Now let's come to second slide. This slide is mainly about medical conditions in labor. Okay. So these are the various diseases we studied about yesterday. let's have a look at what are a few particular things which we have to take care of whenever any such condition is there and the lady is in labor. So first, let's take up cardiac disease. So regarding cardiac disease, one very important thing is that she should be on continuous CTG because there might be chances of fetal distress in between. Next important thing is fluid balance. Now, fluid balance again is very important in cardiac disease. Why? Because very easily the lady may get decompensated. There may be variations in systemic vascular resistance and cardiac output. Means rather than the normal physiological changes in cardiac disease, the things may be slightly different. So we need to monitor fluid balance very closely. Next is early epidural is often desirable. Why? Because in cardiac disease patients, already especially in those cardiac disease where the lady is facing increased systemic vascular resistance challenges, there it is advised that early epidural should be given so that afterload gets decreased and that will improve the labor. Then avoid ergometrine if there is high BP. This we already dealt with yesterday. Last aspect, assist second stage to limit Valsalva. Now this again is a bit controversial. Why? Because now in recent talks, they say that routine shortening of second stage of labor through assisted vaginal birth as such is not recommended. We don't need to use always instrumental delivery to shorten the second stage of labor, but always individualize depending on her NYHA status. That is, if she seems to be decompensated, if she seems to be in real distress, or if she is asking for assistance, that she is really exhausted, then only do shortening of second stage of labor through assisted vaginal birth. Otherwise, allow her to deliver normally. Means no need of routine shortening of instrumental birth unless otherwise indicated because of routine obstetric indications. Then comes sickle cell disease. In sickle cell disease, always our main the most scary thing which we have to be vigilant about is crisis. So to avoid any crisis, keep her warm, keep her hydrated, and keep her well oxygenated. So the three things we have to take care is temperature, hydration, and oxygenation to avoid any crisis. Continuous CTG is must. Prompt analgesia, excepting pethidine, of course. Avoid acidosis or hypoxia. Again, they may precipitate crisis. Hence, avoid any stressor factors. Then comes thalassemia. In thalassemia, again the same thing, continuous CTG. Active management of third stage of labor remains important in all the medical conditions. Here, the peculiar thing is cardiac awareness if iron overload. Okay, so desferrioxamine we can use if she is transfusion dependent and iron overloaded. Desferrioxamine can be safely used during labor infusion as we discussed yesterday. And yes, cross match for PPH risk if she needs. So cross match adequately prior to initiation of delivery. Then comes HIV. In HIV, we all know this viral load criteria is important. Mode will be decided through viral load only. If less than 50, go for vaginal safely. However, if more than 50 or otherwise if not on cart, if adequately means viral load is not maintained at low levels, then especially avoid things like these, invasive procedures like these, like fetal scalp electrode, fetal blood sampling, and also prolonged rupture of membranes, especially if detectable viral load is there. And at any cost, keep on continuing cart. Then comes ICP. In ICP, the time of birth is decided by the bile acid levels. We all know that if it is severe, that is more than 100, then 35 weeks is the limit. Means we have to plan birth by 35 weeks. Okay. And regarding postpartum follow-up, LFT, bile acid follow-up, we have to do at 4 weeks to confirm resolution. This is important. Then in diabetes, again continuous, apart from continuous CTG, sliding scale insulin dextrose, we need to monitor closely the glucose levels during labor. Also after birth, we monitor the neonatal glucose and maintain tight maternal glycemia throughout. So these are the main aspects of labor in these medical conditions. Now let's come to second slide. Third slide, which is about labor analgesia. Now, labor analgesia is again a very favorite topic of our COG, and we need to know regarding what all tenets are available regarding labor analgesia. So these mainly consist of either non-pharmacological or pharmacological. Okay, the first thing they have divided into non-pharmacological. Now, non-pharmacological is basically, they don't want to intervene through any medicines and all. So they have devised these things like 1:1 close care. Then support is such a thing which has been in various trials found to reduce the pain actually. Then few things like music, aromatherapy, acupuncture and acupressure, various trials have occurred and they have been plus minus found to reduce pain during labor. Apart from this, assuming various postures, birthing balls, water immersion. Now, water immersion, you all must have heard that birthing in pools is advised and it has been found to reduce the pain by almost 60%. It has been found in various trials that it reduces the pain by 60%. And what is necessary? That the temperature of the water should be checked hourly. It should be less than 37.5. And whenever the lady feels pyrexic, she should be advised to come out. Of course, few conditions like meconium, if suppose on rupturing of membranes, meconium is found, she needs to come out, she needs to be shifted for continuous CTG. But yes, otherwise, birthing in pools is very safe and can be advised for analgesia. Then comes TENS, that is transcutaneous electrical nerve stimulation. Here, low voltage electrical impulses are sent through this lumbosacral nerves and hence reducing the pain. Sterile water injections have also been found. They are, injected subcutaneously or intracutaneously to reduce the back pain. Then various breathing, relaxation techniques, massage, all these should be adequately supported. The request of the lady should be supported if she is wishing for these. Now, to know about the labor analgesia, it is also very important for us to know regarding the pathways. In first stage of labor, mainly the uterus is contracting and the nerve pathways which are involved are basically these, the T10 to L1. Whereas in second stage of labor, when the baby is distending the cervix and perineum, then the main pathways which come into picture are S2, S3 and S4 pudendal nerves. Okay, so to know about this, it is before reading about labor analgesia, it is necessary that we know about these pain pathways also. Then let's come to the pharmacological measures. Coming to Entonox, first Entonox is actually a mixture of N2O and O2, 50:50, that is in 1:1 ratio. And it is actually the most popular form of analgesia which should be available to all the ladies in UK who are birthing. It is especially helpful for mild pain. Okay. This is especially helpful for mild pain. The lady may experience some nausea, lightheadedness, but as such, there is no major fetal harm. Next, coming to non-opioids and opioid analgesics. In non-opioids, the main most popularly used is PCM. However, PCM can deal with mainly mild to moderate type of pain. Agents like NSAIDs, sedatives, and antispasmodics are not very commonly used in UK. If PCM is not beneficial, they switch to usually opioid analgesics. Okay. And in opioids, I would like to tell you all that pethidine is the most commonly used opioid analgesic all over the world. The most commonly used opioid analgesic all over the world is pethidine. However, followed by diamorphine, codeine, etc. But this IM opioids are associated with sedation, reduced fetal heart rate variability, and also neonatal respiratory depression. As we know, opioids are associated with respiratory depression, so these might lead to, if they are used in the form of analgesics, it might lead to neonatal respiratory depression again. Then comes remifentanil, PCA, and epidural. Now, up to here, pethidine and all, midwives are also licensed to use. Okay. So midwives can use Entonox, midwives can use pethidine, midwives can use non-opioids, PCM and all. But now if the lady is to be given remifentanil or if the lady is to be given epidural, she needs to be in obstetric unit. Remifentanil patient-controlled analgesia is given through IV infusion. It is short-acting. It has also got apnea risk. Hence, monitoring is required. 1:1 care and through continuous SpO2 because it is associated with apnea risk. Coming to epidural, epidural is designated as the most effective and analgesia of choice in any situation. In most of the situations, including asthma, cardiac disease, epidural is the most effective and it should be offered on request at any stage. Okay? Especially when we are initiating oxytocin or if we are inducing, we should always offer epidural. And if it at any stage, suppose initially she refuses and later on she agrees, we should always be ready to offer epidural. However, it is also associated with risks like hypotension, motor block, increased rate of instrumental birth, as we saw earlier, then urinary retention and post-dural puncture headache, approximately 1%. So these are the risks which come along with the benefits of epidural. However, it has not been found to increase the rates of cesarean. It, however, may prolong second stage. We all know that epidural has got main effect on passive second stage. In second stage, it is divided into passive and active. Now, the first, initially when the lady is fully dilated and has not got the urge to push, that is the passive stage. This epidural mainly prolongs the passive stage only. Okay, whether she is nulliparous or multiparous, the epidural will prolong mainly the passive stage up to 1 hour. So whenever the lady is on epidural, increase the duration of passive stage by 1 hour. Keep this in mind. This is very important, okay? That epidural prolongs the passive part of the second stage. Then insertion is itself an indication for continuous CTG. Whenever you are giving epidural, think that you have to offer her continuous CTG. And if she lands up having hypotension, treat through IV fluids, left lateral position, and do an anesthetic review. Now, whenever you are using this epidural, it is required that you ensure an IV access first. No need of preloading and maintenance infusion and running all those things, but securing an IV access is essential. Now let's come to next slide. That is intermittent auscultation versus continuous CTG. So intermittent auscultation is offered to low risk women, those who are in established labor. Okay. Established labor is the keyword here. First stage, here it is very essential to know that how frequently we have to auscultate. After any palpated contraction for up to 1 minute and at least every 15 minutes in first stage, whereas in second stage, after a palpated contraction up to 1 minute, at least every 5 minutes. So this is essential, every 15 minutes and every 5 minutes. Palpate maternal pulse hourly so as to differentiate between maternal pulse and fetal heart rate. So fetal heart rate is a tool, not a standalone diagnostic test. When you have to switch from intermittent auscultation to CTG, this again becomes important. Now, whenever you are doing intermittent auscultation or midwife is doing intermittent auscultation in midwifery-led unit, and if she finds that FHR has risen by 20 beats per minute or more. That means, like earlier I was getting around 120 and 130, but now I'm getting around 150 to 160. So suddenly I noticed that the rate has risen by 20 beats per minute or more. Then this should be a thing of concern. Although we might think that this is in normal range, but it has suddenly risen by 20 beats per minute or more. So then actually what should be your next step? Or whenever there is a deceleration, dip in fetal heart rate, or any new risk factor has arisen, that is any meconium or, or any other concern in fetal heart rate, then it should be followed by more frequent intermittent auscultation. Means not necessarily after every contraction or every 15 minutes, more frequently we should do intermittent auscultation. If concerns are confirmed, the lady should be shifted to obstetric unit. And if CTG is started for intermittent auscultation concern, means she should be shifted to obstetric led unit and started on continuous CTG, means CTG. Okay. If it has been started for just this concern and comes out to be normal after 20 minutes, then we might revert back to intermittent auscultation unless and until the lady is requesting that please keep me on continuous CTG, then only she will be kept. Otherwise, she might be returned to intermittent auscultation. So this is the mode of monitoring, fetal heart rate monitoring, which should be followed. CTG in low risk women, actually if carried out in low risk women otherwise without any indication, might lead to increased interventions without any proven benefit. Hence, it is not indicated for all. Lower escalation threshold should be there when any risk factor is present. Means easily we should switch to CTG whenever we think that any concern is there. And next thing is fresh eyes review should be recommended every hour for those women who are on CTG. Fresh eyes review every hour means that not only the same person must be evaluating every time, because it has been found that some bias may happen. Hence, it is recommended that if there is any confusion, any doubt, then a fresh eyes review should be taken to avoid any bias. So that's mainly about intermittent auscultation versus continuous CTG. Now let's come to reduced fetal movements. Reduced fetal movements for this RFM, a new guideline has come, that is GTG. So please all of you just revise the guideline. No evidence-based normal count has been given that this much count in this much hours is recommended. The maternal perception of reduction is the trigger. She should always be recommended that whenever you feel unusually reduced fetal movements, that is earlier the fetus was moving like this and now the fetus is moving less, according to your perception, please do report to maternity unit. Why? Because various adverse outcomes are linked to reduced fetal movements. The most common adverse outcome, this again is given in the latest GTG, that the most common adverse outcome linked to RFM is FGR, followed by various other adverse outcomes, which include stillbirth, placental insufficiency, etc. The most common one is FGR. First episode, more than equal to 28 weeks. Suppose if she reports to you with reduced fetal movements anytime after 28 weeks, then the first thing you have to do is check whether facility for handheld Doppler, means fetal heart auscultation through handheld Doppler, is available or not. So the first thing you will do is check the fetal heart through Doppler and then try to put a CTG within 2 hours. Then assess for risk factors. If on fetal handheld Doppler, the heartbeat is not audible, then you can check on real-time ultrasound. And if the fetal heart is okay, then take her up for CTG. Do not rely on formal kick count charts alone. Okay. Then if CTG is normal, now here you applied CTG. If CTG has been found to be normal, but reduced fetal movements persist or are recurrent, then arises the need for ultrasound again. Also, if any risk factor like preeclampsia is present, or if any risk factor like IUGR is present, then in these cases also, it is important that apart from CTG, we look then that when the last ultrasound has been carried out. Okay, so then we assess according to the ultrasound that if last ultrasound has been carried out more than 2 weeks back, then she should be posted for ultrasound to check for growth, to check for Liker, and to check for umbilical artery Doppler, the Doppler indices, especially the umbilical artery Doppler. If there is any risk factor for fetal anemia or any suspicion of feto-maternal hemorrhage, then MCA-PSV if required within 24 hours. And again, another bad thing is recurrent reduced fetal movements. If she has been repeatedly coming to you that again and again my fetus is moving less, then she becomes at higher risk. And this is the time when she should be evaluated by a senior obstetrician. Individual surveillance should take place and should be taken up for delivery planning. So anytime if she faces reduced fetal movements before labor onset, this becomes an indication of continuous CTG in labor. Okay, so if there are no other risk factors, if everything is fine, but she has been reporting with reduced fetal movements before onset of labor, then she should be preferably put on continuous CTG. So these are the main components of reduced fetal movements. Two more things I would like to add, that if suppose some lady is reporting to you with exaggerated fetal movements, then also you need to take her up for CTG. Another important thing, if suppose she reports to you with no fetal movements up till 24 weeks of gestation, till 24 weeks are over and still she hasn't started perceiving any fetal movements, then is the time you should check whether anomaly scan has been carried out or not, and then you should refer her to fetal medicine for opinion. Recurrent RFM is more concerning than a single episode. Escalate to growth scan and consider the timing of birth. Now next come to another very important point, that is preterm labor and PPROM. The key points here are, whenever a lady is reporting to you with suspected signs and symptoms of preterm labor, first look at her gestational age. If she is less than 30 weeks, that is up to 29 weeks 6 days, treat immediately without thinking. Means this is the gestational age at which she directly requires treatment. Don't delay for tests. However, if she is 30 weeks or more, then is the time that she should be taken up for test first. So which one is the preferred test? The preferred test is TVS. TVS you will do for cervical length. And what is the threshold here? The threshold is 15 mm. Don't confuse with 25 mm, which is for cervical cerclage. Here for preterm labor, the threshold is 15 mm. So the first thing, any lady coming to you in suspected preterm labor, if she is 30 weeks or more, take her up for TVS for cervical length. If it is less than 15 mm, then she is at risk of preterm labor and requires treatment. Or sometimes TVS might not be available, then comes the role of fetal fibronectin. So if fetal fibronectin you are carrying out, the levels or the threshold is 50 nanogram per ml. So 15 and 50, remember this. If fetal fibronectin comes out to be more than 50, not less than 50, more than 50 nanogram per ml, then again she is at high risk of going into preterm labor. So that demands treatment now. So treatment will be in the form of either tocolysis and or steroids and or Maxelf. These three are the main treatment aspects, components. Tocolysis, the first line is nifedipine, second line is oxytocin antagonist, that is etosiban. Tocolysis is especially targeted to buy time for steroids and transfer. Steroids, when to offer, when to consider. Steroids should be offered between 24 to less than 34 weeks. However, you can consider up to 36 weeks, less than 36 weeks. Maxil for neuroprotection should be given if if you think that she is likely to deliver within 24 hours. So this is the time when you think that neuroprotection is required. If she is likely to deliver within 24 hours, then offer if she is less than 30 weeks and consider up to 34 weeks, up to less than 34 weeks. Then regarding PPROM. Now, one more thing. If suppose these both are not possible, if she is coming to you in preterm labor more than 30 weeks, neither you have got TVS for cervical length, nor you have got the facility of fetal fibronectin, then better to treat. Second, never use both these things to decide for treatment. You are doing TVS for cervical length also and fetal fibronectin also, no need. Only one of the two you will do. Now next come to PPROM. Diagnose on speculum whether pooling is visible or not. If pooling is visible, clinically or visually, you are sure of PPROM. If no, you are doubtful, pooling is not visible, then you can carry out these two tests of vaginal fluid. Placental alpha microglobulin 1 or insulin growth factor binding protein 1. Avoid digital examination and nitrazine. Antibiotic, what you will give? You will give, the preferred one is erythromycin for 10 days or till the time she delivers, whichever is sooner. Never co-amoxiclav because it poses a risk of neonatal necrotizing enterocolitis. Tocolysis, try not to give in PPROM. It's not recommended in PPROM because it increases the risk of chorioamnionitis. Try to prolong the gestation up till 37 weeks if she is stable because expectant management has been found to improve the neonatal outcomes. So try to do expectant management and take her up to 37 weeks. So pearl point, in PPROM, the antibiotic is erythromycin. Co-amoxiclav is contraindicated. It might lead to neonatal necrotizing enterocolitis. Next, let's come to flowchart drill, CTG and escalation. CTG, we all know that we classify, you must have heard of the term Dr. C. Bravado. In CTG, while interpreting CTG, we all know that few things we use. First is determining the risk, then contractions, then baseline rate, accelerations, if there it's a good feature, then variability, then decelerations. So contraction, baseline fetal heart rate, variability and decelerations, each of these features we classify either as white, amber or red. And depending on how many white features or how many amber features or how many red features are there, we classify the overall CTG into normal, suspicious and pathological. Then decelerations, if present, may be of three types or maybe sinusoidal pattern, early variable or late deceleration. Then if the CTG is pathological, that is either two amber features are there or any one feature of red is, any one red feature is there, then it's classified as pathological CTG. Immediately start with conservative measures and lead to escalation of care, and it might require expedition of delivery if it's not resolving on the basis of conservative measures alone. Another very important thing is acute bradycardia. Now in acute bradycardia, what you do 3-minute review. If it is persisting for more than 3 minutes, you should be cautious that yes, something wrong is going on. We might need to escalate the delivery immediately. So escalate the delivery, be on the lookout whether it is persisting or not. Then if it is persisting for up to 9 minutes, then decide for delivery anyhow. Even if it starts resolving after 9 minutes, deliver. If it resolves in less than 9 minutes, then you can continue watch, you can continue supervision, you can continue conservative measures. But any bradycardia persisting for more than 9 minutes, definitely you have to deliver. Delay in labor, induction of labor and hyperstimulation, and preterm prevention also we will be dealing with now. So now let's come to CTG classification, another very, very important slide, that when to classify as white, when to classify as amber, and when to classify as red. Now, depending on contractions, if there are less than 5 contractions in 10 minutes, means up to 4 contractions in 10 minutes, we are comfortable and we keep it as white. If contractions become 5 or more in 10 minutes, then it's a bit of concerning feature and it is classified as amber, or it is called as hypertonus. Red is not in contraction, means if it is more than 5, it is only amber. There is nothing as red feature in contractions. Then coming to baseline, 110 to 160 is stable. Okay, 110 to 160 is stable. Again, this thing I would like to highlight that as an intermittent auscultation, a rise of 20 was significant, concerning. So here also, if suppose it was earlier 120 and now it has become 150, so it has risen by more than 120, it has risen by more than 20 beats per minute from start. So it becomes amber, even if the absolute value lies between 110 to 160. Okay. Then between 100 to 109 becomes amber, or sometimes the baseline is so fluctuating that you are unable to determine. So if you are unable to determine, then again it's amber feature. Then clearly less than 100 is red, more than 160 is pathological, means red. Any red makes the CTG pathological. Okay. Then comes to variability. Between 5 to 25 is the desired variability, so will be classified as white. If variability becomes less, that is less than 5 for 30 to 50 minutes, then it is amber. And if this less than 5 prolongs for more than 50 minutes, then it becomes red. Similarly, more than 25 for up to 10 minutes is amber, but more than 25, if prolongs for more than 10 minutes, it becomes red. And remember, sinusoidal is always red. Sinusoidal means immediately you have to take her up for cesarean section if delivery is not imminent. Then comes the most confusing one, decelerations. If there are no decelerations, you are happy, keep in white. Even if there are early decelerations, they signify head compression, still you are not concerned, it's still white. Even variable decelerations, which are not evolving to have concerning characteristics. Not evolving means they are not evolving to have concerning characteristics, then they remain white. If there are no concerning characteristics, no need to worry, then they remain white. But if they are repetitive variable with any concerning characteristic, but for less than 30 minutes, then it falls in amber. Repetitive means that they are present for more than 50% of contractions. Means you count the number of contractions in your CTG and you count the number of variable decelerations. If you notice that variable decelerations are there for more than 50% of contractions, means you take out half of the number of contractions, and if the variable decelerations are more than that number, then it is repetitive. And concerning characteristics, You all know that there are various concerning characteristics: the reduced variability within, slow return to baseline, loss of previously present shouldering. All these are concerning characteristics. So if repetitive with any concerning characteristics but for less than 30 minutes, then it is amber. Non-repetitive variable with any concerning characteristics for more than 30 minutes, again falls in amber. So if any of these is there, it is amber. Now, this is a recent update. Please all of you make note that any late deceleration is red. Any late is red, any duration. Or repetitive also, concerning characteristic also, and more than 30 minutes also. Then again it becomes red. Or again acute bradycardia or prolonged deceleration for more than 3 minutes. You have to expedite the delivery, it's red. So if all the features are white, it's normal. Any one feature is amber, it is suspicious. Any one red, then it's pathological. Or 2 amber again makes the CTG pathological. So according to 2025 update, late decelerations are red, always red, regardless of duration. Okay. So this was regarding CTG classification. Now let's have a quick look at the deceleration patterns, the schematic traces. Early deceleration is usually because of head compression, and it's benign, as we already saw. Early deceleration, yes, because of head compression, it's benign. And what happens here is that the nadir of the contraction is coinciding with the nadir of the deceleration is coinciding with the peak of the contraction. What is happening in late? Late is often bad, as we saw that it is associated with uteroplacental insufficiency. Here, the nadir of the contraction is following the peak. The nadir of the deceleration is after the peak of the contraction. Means peak of contraction is here and the nadir of the deceleration is here. So you can see that always it is after it. Wherever the peak of the contraction is there, the nadir of the deceleration is immediately after it. Whereas variable, which is associated with cord compression, here it may be variable. It might sometimes, coincide, sometimes it might not coincide. It may go somewhere else. But variable means the word itself says that variable deceleration, it is not necessarily coinciding with contraction. That's why the word repetitive is here, that you have to count the number, that whether if there are 5 contractions and there are 3 decelerations, that means it is repetitive, means it is associated with more than 50% of the contractions. So always remember, early is because of head compression, late is because of uteroplacental insufficiency and always red. Variable is because of cord compression and it may be white, amber or red. Sinusoidal is like this, fluctuating. Whole of the baseline seems to be fluctuating like this. So it is associated with fetal anemia, often vasa previa or bleeding abruption. So it is always red and the delivery needs to be expedited. Now let's come to what actions you have to take whenever the CTG is suspicious and if it is pathological. Now, white features leading to normal CTG is always good. We have to just continue with our routine intrapartum care. Any one amber feature makes the CTG suspicious. So what should be our first measure? The first measure, see, general things we will always do. We will assess the woman fully. We will check for any risk factor. We will take any maternal observations, that temperature is okay or not, pulse, BP and all those things. Then the next thing which we have to start with always is conservative measures. Whenever the CTG looks suspicious, start with conservative measures. Also look if any accelerations are there or not. If any accelerations are present, then likely acidosis is not there. Fetal acidosis is unlikely. Then look for any intrapartum risk. Now here, this intrapartum risk means that if suppose there is any sepsis or there is any meconium or the progress is slow, if any kind of such risk factors are present, then look for urgent obstetric or senior midwife review. And what you have to do here is fetal scalp stimulation. Okay. So here fetal scalp stimulation has got a role if the CTG is suspicious on the background of any intrapartum risk factor. If conservative measures and fetal scalp stimulation is not working, then of course expedite the delivery. So this is the routine action which you have to do following suspicious, that is any one amber feature. Then comes pathological. Now in pathological, where any one red or two or more amber features are there you have to seek for urgent obstetric or senior midwife review earlier only. Exclude any acute events first, because if any acute events are there, like cord prolapse or abruption or rupture, then you have to immediately think about delivering. You don't resort to conservative measures then. Okay. Then if acute events have been excluded, then you start with evaluation and conservative measures first, just like in suspicious, but you keep your threshold low. Even if after conservative measures, the CTG stays pathological, repeat urgent review and expedite the birth. Here, the threshold should be low, especially if any risk is evolving and you feel that CTG is remaining pathological, your conservative measures aren't working, then please expedite birth. What comes in conservative measures? Left lateral position is conservative measure, means the first thing you will do is reposition the patient to left lateral, reduce or stop oxytocin, remove any propes if already there. You may also offer tocolysis, especially if hypertonus is there. You can give terbutaline 0.25 mg subcutaneous. IV fluids only if hypotensive or septic. See, routine facial oxygen, amnio infusion, these measures are usually not recommended. IV fluids are recommended only if she is hypotensive or septic. Okay, so the pearl point here is IV fluids are not a treatment of an abnormal CTG unless the mother is hypotensive or septic. Facial oxygen is also not recommended as it may harm the baby. Now let's come to acute bradycardia or prolonged deceleration for more than 3 minutes. Let's have a look here. Sustained fetal heart rate drop. If suppose baseline fetal heart rate was going like this and suddenly it has dropped, or you find a single deceleration which has not returned back, it is continuing for 3 minutes or more, then it is quite concerning, always a red feature, and requires urgent obstetric review. It requires you to exclude any acute event first, which may be in the form of abruption, rupture. You have to assess the whole situation of the lady. If she is previous cesarean section, you have to be on the lookout for rupture. Do upper vaginal examination to exclude any cord prolapse. If any of this is present, expedite delivery. Otherwise, immediately commence conservative measures and summon neonatal support. The summon neonatal support is also important because delivery might be needed urgently. So after 3 minutes, if you notice this 3 minutes of prolonged deceleration, senior review is must. If acute event, expedite now. Then you repeat evaluation at 6 and 9 minutes. If beyond 9 minutes this bradycardia is persisting, then you have to already start escalating or expediting birth. Even sooner if the risk is significant. However, if fetal heart rate recovers at within 9 minutes, then you can reassess your decision with whole picture along with the wishes of the woman. You can counsel the lady and take her wishes also into account. But if it has already exceeded, means already persisted for up to 9 minutes or more, then expedite birth at any cost. So the 3-minute review, 9-minute delivery rule is a classic SBA. Recovery before 9 minutes prompts reassessment. Now let's come to another very important topic, that is delay in labor. So delay in labor, first and second stage, as we saw, So let's first come to first stage. Now, first stage, as we all know, starts from when the labor pains have started. Of course, the uterus has started contracting and cervical changes have also begun. But when it is established, when it is latent, latent is when the contractions are still irregular and cervical dilatation is less than 4 centimeter. Whereas established labor is when the uterus has started contracting regularly, regular contractions have begun and the cervical changes, cervical dilatation has become more than 4 centimeter. Now, it is recommended that you carry on vaginal examination every 4 hours. If suppose you find less than 2 centimeter dilatation in 4 hours, means earlier she was 5 centimeter, now in 4 hours you expect her at least to be 7 centimeter or more, means you expect a dilatation of 2 centimeter or more. If it is not so, that is she has dilated less than 2 centimeter in 4 hours, this is the time when you will call suspect delay. Suspect delay. What you will do in suspected delay? Assess all aspects, offer support and pain relief, and then the first thing you will do is reassess in 2 hours. If in 2 hours, again the progress remains slow, that is in 2 hours, you expect the progress to be at least 1 centimeter. If it didn't happen, then it is the time when you diagnose delay. So when it is suspected delay and when it is diagnosed delay, this should be very clear to all of you. Now, as soon as you diagnose delay, then you have to act. You have to first do amniotomy if the membranes are intact. Reassess her after 2 hours of amniotomy. Okay. Now, amniotomy can also be done at midwifery led unit. No need to shift her to obstetric led unit at this point of time. After doing amniotomy, the time should be examination after 2 hours. If still the things are same, the progress is inadequate, then is the time when you need to shift her to obstetric unit. In obstetric unit, you will first offer epidural, you will put her on continuous CTG, and then you will start her on oxytocin. So shifting to obstetric led unit, offering her epidural and offering her continuous CTG. These are prerequisites before starting oxytocin. Then once you have started oxytocin, syntocinon titration, then you re-examine again after 4 hours. After amniotomy, you are re-examining after 2 hours. After oxytocin, you are re-examining in 4 hours. If progress is still less than 2 centimeter, reassess 4 hours after adequate contractions. If you think that contractions are still inadequate or despite adequate contractions, cervical dilatation is inadequate, then take a senior opinion and consider about cesarean section. So this is regarding first stage, suspected delay, diagnosed delay, and what actions you have to take. If suppose the membranes are already ruptured and you are suspecting delay, then once you diagnose delay, immediately switch to oxytocin. Then this portion will be skipped, but the time duration will be same. Now let's come to second stage. Now in second stage, this is important that first, when she is passive and when she has started active pushing, then this is the active stage. Now, passive stage usually stays for half an hour to 1 hour, depending she is nulliparous or multiparous. What epidural does? Epidural prolongs the passive stage by approximately 1 hour. Especially in nulliparous women, suppose she became fully dilated at 5 a.m., then you can allow up to 1 hour, means generally 1 hour of passive stage if routinely it is there. If she's on epidural, it might be up to 2 hours. Means passive stage can be prolonged by 1 extra hour if she's on epidural. This can happen for any nulliparous also. In multiparous, it is generally less. Then now let's come to pushing. Now this suspect delay and diagnosed delay is usually in context to active second stage of labor. Okay, when she has already started pushing. Now let's understand this through an example. Suppose she was fully dilated at 5 a.m. and she was on epidural, and now since 7 a.m. she has started pushing actively. Because of epidural, her passive stage was prolonged by 1 more hour. So it's okay. But maximum up to 2 hours you can allow passive stage on epidural. Beyond that, you have to initiate delayed directed pushing. So suppose she starts pushing at 7 a.m. Then at 8 a.m. you re-examined her. You found that the progress is not adequate. Still, the baby hasn't delivered. The findings are not favorable. Still, the findings are same. So that is the time when you suspect delay. That is, after 1 hour of active pushing, if you find that the findings are same, then you suspect delay. Then at 9 a.m., when you found that still the findings are same, even after 2 hours of active pushing, that is the time when you diagnose delay, and then you have to take the decision for operative delivery. Operative delivery may be in the form of instrumental delivery or in the form of cesarean section. And birth is expected within 3 hours of active second stage. That is by 10 a.m. The baby should be in your hands. So that's why it is said that suspect delay after 1 hour of active pushing, diagnose delay after 2 hours of active pushing, and birth is expected within 3 hours of active pushing. That is active second stage. That is, birth is expected within 3 hours of active pushing. Now, in multiparas, the things will be slightly different. The things will be halved. See, epidural delays pushing up to 1 hour in multipara. Here in multiparas, the things, this passive second stage, maximum up to 1 hour can be allowed if she is on epidural. In nullipara, it was up to 2 hours before active pushing initiation. In multipara, passive stage, even if she is on epidural, up to 1 hour maximum passive stage can be allowed. Now, when she starts pushing, suppose at 7 a.m., so 30 minutes of active pushing, that is at 7:30 you examine her. If the findings are same, then you suspect delay. Then again at 8 you examine her. Okay. If the findings remain same, that is after 1 hour of active pushing, you diagnose delay. Here you diagnose delay after 2 hours of active pushing in nulliparous. In multiparous, you diagnose delay after 1 hour of active pushing. And this is the time when you decide about operative delivery, means either instrumental or cesarean. And within 2 hours of active second stage, that is at around 9 a.m., by 9 a.m., the baby should be in your hands. That is within 2 hours of active pushing, the baby should be there with you. Birth is expected within 2 hours. So this is regarding second stage delays. Suspect delay, diagnose delay until when the birth is expected. Now this is to be followed regardless of what is given in assisted vaginal birth GTG, but this is the whole clear-cut classification of how much passive, how much active, how much pushing, and when to go for instrumental birth or operative birth. If she is ineligible for instrumental delivery, then cesarean section. Pearl is first stage delay, amniotomy, then oxytocin on the 2-hour, 4-hour clock. Second stage delay, instrumental or CS once this limits are reached. Hope it's clear to all of you. Now let's come to induction of labor. Indications, first have a look at indications. Post dates, start offering induction at 41 to 42 weeks. PPROM, preeclampsia at 37 weeks. Diabetes at 38 to 40 weeks depending on what kind of diabetes is there. FGR depending on whatever are her Doppler findings. And cholestasis depending on the bile acid levels. These are common indications of induction of labor. First, assess favorability with Bishop score. This Bishop score is important. 7 or more is favorable. Okay. Membrane sweep is offered from 39 weeks in low-risk women. When you will look at antenatal care, when different visits at different gestational ages are given, at 39 weeks, we offer membrane sweep. Okay. Methods: vaginal PGE2, prostaglandin, mechanical balloon, amniotomy plus oxytocin, or oral misoprostol. Any of these methods can be used for induction. They are licensed. Oral misoprostol is although off-label, but yes, for IUFD and all, misoprostol is given vaginally. Detail coming to hyperstimulation, which is one of the risks associated with induction of labor. Easily the woman can go into hyperstimulation. More than 5 contractions in 10 minutes with any FHR change if visible. If there is any CTG, if CTG starts getting affected because of this hyperstimulation, then is the time when you have to remove the prostaglandin, stop oxytocin. If propess is inside, remove it. If oxytocin is running, prefer to stop it. And if required, if the things are not getting well, then terbutaline, in guideline it is given 250 micrograms subcutaneous you have to give, but in one of the recalls even IV it was given, 500 microgram IV can also be given. Then after previous cesarean section, we all know there is high risk of rupture. So after CS, avoid prostaglandins. Mechanical is often preferred. So if any scenario is given where the lady is previous cesarean and you are asked about the induction method, prefer to choose mechanical. And always, if you are doing VBAC, put her on continuous CTG. Then once contractions are established, oxytocin is running, you have to do continuous CTG. Misoprostol hyperstimulation is again managed identically. Either if vaginal misoprostol is put, you can remove it. Also, if hyperstimulation is there, you can offer tocolytics. Now, uterine hyperstimulation is the key hazard of induction of labor. Remove the agent, give terbutaline, and read the CTG for any late or prolonged decelerations, and then take action accordingly. Now coming to preterm prevention and cerclage. Most of the things we have already gone through. Wherever there is suspected preterm labor and she is less than 30 weeks, treat immediately. More than 30 weeks, test first. If cervical length is less than equal to 15 mm or fetal fibronectin is more than 50 nanogram per ml, then only treat. What antibiotics are to be given in PPROM? Erythromycin for 10 days or till delivery, whichever comes sooner, never coamoxiclav. Steroids are offered till less than 34 weeks, considered till 36 weeks. Maxilf neuroprotection offered less than 30 weeks, considered till less than 34 weeks. Tocolysis is especially not recommended in PPROM. Then regarding cervical cerclage and progesterone, what is given in the guidelines? See, GTG has classified cerclage into either history indicated or ultrasound indicated cerclage. Now, what is history indicated cerclage? Wherever the woman has got 3 or more prior preterm births or mid-trimester losses. This number is essential to remember. It should be 3 or more prior preterm birth or mid-trimester losses, that is birth between 16 to 34 weeks. Okay. So if she has undergone birth between 16 to 34 weeks, then it is called as prior preterm birth or mid-trimester loss. Then is the time when you will, although she will be classified as high risk, but in this history indicated cerclage is justified. You can straight away counsel her and say that yes, at 11 to 14 weeks, I will carry out a history indicated cerclage for you. If she has delivered 3 times previously, prior preterm birth or mid-trimester loss. Another category is ultrasound indicated. So this was history indicated. Another is ultrasound indicated. When you will do ultrasound indicated, if suppose she has got any one prior loss at 16 to 34 weeks, then she is high risk, and then she will be told to undergo cervical length screening. If cervix comes out to be less than equal to 25 mm, now here contrast with this. Here preterm labor was 15 mm. Don't confuse. This is 25 mm. Cervix comes out to be 25 mm or less on serial scanning at less than 24 weeks. She is offered serial scanning or at least a single scan, depending on whether she is in high risk or intermediate risk category. If she is in high risk category, she will be offered serial scanning between 16 to 24 weeks. If she is in intermediate risk category, single cervical length screening will be carried out at around 18 to 20 weeks. If short cervix comes out to be there, then you will carry out ultrasound indicated cerclage, or plus minus progesterone also you can give. Now, according to NICE guideline, vaginal progesterone can be given if incidentally short cervix is found in a lady which has got no risk factor. Even in the absence of any risk factor, if the lady has found to be having short cervix that is less than 25 mm or less, then consider prophylactic vaginal progesterone 200 mg capsules, okay? Not cerclage. So one prior loss, but cervix is more than 25 mm, then you have to keep her under surveillance. But in multiple pregnancy, never choose the option of cerclage. We don't do. Okay. So this is in brief regarding what action you will take depending on the scenario. Pearl points: 3 losses indicates history cerclage. 1 loss plus short cervix indicates ultrasound cerclage. Short cervix with no history, you can consider prophylactic vaginal progesterone. Twins, you have to just do surveillance. No need to do cerclage. Next, let's come to intrapartum complications and operative deliveries. Now, in assisted vaginal birth, first let's look at the indications and prerequisites. So, key points: incidence is 6 to 12%. It has been found that epidural increases the rate. Why? Through decreased Ferguson reflex and endogenous oxytocin. When epidural is given, this reflex decreases, endogenous oxytocin release decreases, hence the rate of spontaneous birth decreases, and usually assisted vaginal birth is required. Main indications can be classified into fetal, maternal, and labor. In fetal, whenever CTGs stop using these words, non-reassuring. If CTG is suspicious or pathological, if there is prolonged deceleration, or if there is cord prolapse in the second stage of labor. So whenever you think that she is eligible for assisted vaginal birth in any of these situations, try to expedite the delivery through instrumental birth. Or the mother is having any cardiac condition, respiratory condition, hypertensive, neurological disease, or she is exhausted. Now, these also don't demand routine shortening of second stage of labor now. But if you have to always individualize the case. If suppose the lady looks to be exhausted and you think that shortening the second stage of labor would really help her condition, then you should individualize, especially in NYHA 3-4 classes, or whenever she demands help, she requests for assistance, then is the time when you have to assist her with instrumental vaginal birth. Then labor specific indications. Of course, when she has already pushed for 2 hours or more, there is malposition, minor disproportion, then you can use assisted vaginal birth. Then prerequisites, always this is to be kept in mind. Never choose the option of assisted vaginal birth if these are not met. She should be fully dilated. The membranes should be ruptured. This presentation should be vertex, and position should be defined, preferably head. Then the presenting part should be less than 1/5 palpable. The station should be at or below spines. There should be no caput or molding, or there should be minimal caput or molding. The bladder should be empty. She should be on adequate analgesia so that she doesn't feel distressed. Consent should be there, at least verbal, and the operator should be skilled. These are the important prerequisites which must be met before opting for assisted vaginal birth as your preferred option. Next, what kind of analgesia? For outlet and low forceps deliveries, pudendal and local are sufficient. For mid cavity or trial, that is when it becomes more invasive, and if trial is being given in theater, regional, that is epidural or spinal is preferred. Okay. So this is regarding incidence, indications, prerequisites, and analgesia. Never attempt if you find head more than 1/5 palpable or quite significant caput or molding and station above the ischial spines. High instrumental delivery is no longer routinely recommended. Hope it's clear. Now let's come to, yes, some of the pearl points again. Document position and station. Example, she is ROT at +2. Always check for this before going for instrumental delivery. Decision rests on accurate position, station, caput molding, and asynclitism. That is sagittal suture deviation. All these things need to be individually seen when opting for instrumental vaginal birth. Now let's come to instrument selection. Forceps versus ventouse, station ladder. Now regarding forceps when it is preferred and ventouse when it is preferred, this often we are baffled that when to choose forceps, when to choose ventouse. Actually, the first and foremost thing which the RCOG says is that in whatever, if there is no contraindication, then in whatever instrument the operator is more confident, that has to be chosen. Of course, there should not be contraindication for that, but there is no specific preference for anyone. Whatever the operator is more comfortable to choose or is more comfortable to apply, that should be chosen. Forceps are more favorable if rotation is required, if controlled traction is required. Then this is very well known to us that if we have to apply for instrumental delivery at less than 34 weeks, preferably forceps is to be applied. For after coming head of breech, Piper's forceps, here again forceps is to be applied. Bradycardia, again forceps has got slightly higher effectiveness and less failure rates, so prefer forceps. Regarding the type of forceps, low cavity forceps or sometimes mid cavity forceps, you can use navel bands or Simpsons. Usually low cavity forceps is navel bands. Wrigley is usually outlet, and wherever rotational you have to carry out. That is when the head is occipito-transverse or occipito-posterior. Of course, the rotation should be less than 45 degree. Keel end is to be applied. Rotation when you have, it is not 45 degree, means wherever you have to do rotation, their keel ends you have to choose. Then coming to ventouse, direct occipito anterior. Ventouse is all preferable when there is direct occipito anterior. And one advantage of forceps is that it has lower maternal trauma. Forceps poses higher maternal trauma rates, higher rates of perineal tears as compared to ventouse. There is one important point, flexion point with respect to application of forceps. It is 3 centimeter anterior to occiput. So the cup of the forceps should be stationed there. And you have to gradually escalate the pressure from 0.2 to 0.7 to 0.8 bars, and then you have to exert the force. Now, contraindication of ventouse is, of course, less than 34 weeks, face or brow presentation, fetal bleeding diathesis. All these are contraindications. Don't prefer to apply for Ventouse if any of these is there. Complications. For forceps, as we discussed, maternal perineal trauma is more. So OSE is more common with forceps. Facial nerve palsy and skull fracture. Both these are more common complications associated with forceps. Whereas with Ventouse, you will see that hemorrhage, that is cephalhematoma, subgalilean and retinal hemorrhage, chignon. Of course, they subside with time. Sometimes they might require urgent NICU admissions or prolonged admissions also. And they are more common with Ventouse. Since hemorrhage is there, cephalhematoma is there, then increased chances of jaundice might also be there. And Ventouse has got slightly higher failure chances. In one attempt, forceps has got higher delivery chances as compared to Ventouse. That's why in bradycardia, forceps is preferred. Now, classification by station. Wherever the scalp is visible, she is occipito-anterior, less than 45 degree, it's clear-cut outlet. Below plus 2 centimeter means above outlet, but below plus 2 centimeter is low. Plus 2 or above, below ischial spine, but above plus 2, head engaged, is mid cavity. It usually needs regional analgesia. And high forceps is usually not done. Go for a cesarean section straight. Wherever you have to do a rotation, preterm or after coming head, go for forceps. Wherever direct occipito anterior at low station and you think that Ventouse is preferable, then you can safely go for Ventouse. Now regarding trial, abandonment and aftercare. Wherever you think that the trial of instrumental vaginal delivery, the success may be uncertain, then prefer to do in theatre. In theatre, prefer to do under regional anesthesia, and senior anesthetist, pediatrician, all should be available, and you should be ready to convert to cesarean section immediately if in case it fails. Regarding place of birth, outlet and low are often applied in labor room, whereas mid cavity and trial are often applied in theatre. We can't say always, but often, because we have to individualize keeping other factors into account like parity, like BMI. So all these might change the place of delivery, but this station usually can be done here. Abandonment, when there is no progressive descent with each pull or delivery is not imminent, then escalate to cesarean section rather than switching the instruments and persisting with doing instrumental delivery. It's safer according to RCOG to switch to second stage cesarean section as compared to switching off instruments, unless and until competent operators are there and they think that instrumental delivery is very imminent. Antibiotics, single dose IV co-amoxiclav within 6 hours of cord clamping after operative vaginal birth reduces maternal infection, not for episiotomy alone. If only episiotomy has been given, no need of antibiotics. Anti-D definitely you have to give if mother is D negative. Now, never apply an instrument with head more than 1/5 palpable or above spines, that is high forceps is not to be applied. And also parabdominally check. Head should not be more than 1/5 palpable. Preferably it should not be palpable, but more than 1/5 absolutely not palpable. Never use Ventouse less than 34 weeks or for face presentation at all. Always confirm full prerequisites and give post-procedure co-amoxiclav. Now let's come to another important aspect, that is ECV, external cephalic version. Success rate is around 50%. In multipares, the success rate is 60%. In nullipares, it's 40%. It reduces the chances of non-cephalic birth and CS. However, these numbers are slightly important. Less than 3% revert, but 3 to 7% may turn after a failed attempt. Timing, offer from 37 weeks Nulliparous means in nulliparous it can be offered from 36 weeks, in multiparous offered from 37 weeks. Tocolysis with a beta mimetic. Suppose first attempt failed, then you can give repeat attempt with tocolysis. Okay. Routine regional as such is not recommended. Contraindications, that is when you don't have to do major previa, if antepartum hemorrhage, that is bleeding, has happened within a week, if the CTG is abnormal, always pre and post ECV you have to put CTG. So if there is abnormal CTG or membranes have already ruptured, in multiple pregnancy for first twin, rhesus isoimmunization has already occurred, or if the lady is not ready, she has declined, then please don't do ECV. For second twin, you can do ECV and IPV, but for first twin, don't. Safety, this percentage is important. Emergency CS within 24 hours might be required. Transient bradycardia is common. If she is D negative, give an anti-D and followed by FMH test. Maximum 4 attempts can be made in 10 minutes, and electronic fetal monitoring you do before and after. So these are the safety points which you have to take care while performing ECV. Pearl point, in term breach, whenever term breach patient is given to you, always look for the option of ECV in your options. Offer ECV first. 50% success rate is there and higher in multipara. After 1 CS, ECV risk is approximately same as that in unscarred uterus, so you can give. Then coming to mode of delivery and selection in breech. Coming to perinatal mortality. Now, this should be kept in mind that for a breech patient, if the lady is breech, then vaginal delivery is safer for the lady, and cesarean section is safer for the infant. So keeping this in mind, cesarean section after 39 weeks, the incidence is 0.5 per thousand. This is perinatal mortality incidence, means perinatal mortality is, if we straight away go for cesarean, it's 0.5 per thousand. If you do planned vaginal breech birth, then it rises 2 per thousand. Whereas for planned cephalic birth, just contrast it with this number. For planned cephalic birth, perinatal mortality is 1 in 1,000. For planned vaginal breech birth, it doubles 2 in 1,000. Whereas for cesareans, if you straight away go for cesarean section, then it is 0.5 per thousand. Maternal, coming to maternal aspect, the risk is lowest with successful vaginal birth, but highest with emergency CS. With elective CS, it is still maternal risk is still less, but highest risk to mother is when she was trying for vaginal birth, but emergency CS had to be done, which is actually needed in 40% of planned vaginal breech birth, emergency CS. Then the maternal risk is the most. Recommend CS. Now, in which cases you will counsel the lady to go for elective LSCS, especially when the baby is having hyperextended neck, fetal weight is more or less, more than 3.8 kg or 10th centile, footling, hyperextended neck, footling, or fetal compromise or any CS indication. This would be natural that if fetal compromise is there or any other cesarean section indication is there, then definitely we'll counsel for cesarean. But remember these two, hyperextended neck and footling, counsel for elective cesarean section. So what is essential? Adequate case selection, strict protocol, and skilled attendants, all these are essential for planned vaginal breech birth if you are opting for it. In twins, if first twin is breech, prefer planned cesarean section. In second twin breech, cesarean as such is not recommended, vaginal birth is okay. Now, pearl point, selection plus skill can make planned vaginal breech nearly as safe as the vaginal cephalic birth, but any red flag sign, don't take risk, shift to cesarean section. Now, intrapartum conduct. Wherever you are conducting planned vaginal breech birth, prefer continuous electronic fetal monitoring. Induction as such is not recommended. You can augment only if contractions are low and prefer to give epidural in such cases. But don't usually induce. Induction is usually not recommended. In second stage, allow for passive descent first without handling much. If breech is not visible within 2 hours of full dilatation, recommend cesarean section, okay? Semi-recumbent or all force position is preferable. Conduct assistance without traction. Hands-off technique you must have heard. This is preferable. When you have to intervene, these numbers are important. If there is more than 5-minute buttock to head delivery interval or more than 3-minute umbilicus to head delivery interval. In such cases, grasp the pelvic girdle, but never hyperextend neck. Always try to deliver the breech by suprapubic flexion. Never extend. Maneuvers, what you can use? Lobsets are used for nuchal arms. Mauritius smelly wheat technique or forceps for aftercoming head. Suprapubic pressure to maintain flexion. But Burns-Marshall is not advised, remember. According to latest evidence, Burns-Marshall is not advised because it leads to hyperextension. It might lead to cervical nerve injury, spinal cord injury in the baby. Hence, it is recommended not to advise Burns-Marshall maneuver. So, breech pathway, breech detected at term of a ECV first. If it is successful, it's good. We can plan vaginal cephalic birth. If it fails or the lady declines, then counsel regarding the mode of birth, whether she wants to go with planned vaginal breech birth or cesarean section, and then act accordingly. Never apply traction or hyperextend the neck. One thing. Second thing, never induce a footling breech vaginally. Footling and hyperextended neck, these two are contraindications to vaginal breech birth, so prefer not to deliver vaginally. Now, birth after previous cesarean section. VBAC. Who are suitable? Singleton, cephalic presentation, 37 weeks or more with single prior lower segment cesarean section can be taken up for vaginal birth after previous cesarean section. What is the success rate? Very important. This overall success rate is 72 to 75%. This percentage is very, very important, often asked in exams. However, if she has underwent a previous vaginal birth or prior VBAC, then her chances will increase. The chances will increase from 75 to 85%. So these two percentages are very important. When VBAC is contraindicated, previous uterine rupture has happened, or there is classical or inverted T-scar, major previa or any other indication already is there for cesarean section, counsel her not to go for VBAC. What is the rupture risk? This again is very important number. Approximately 1 in 200, that is 0.5%. Spontaneous, 0.15 to 0.4%. In induced, it increases slightly. If the labor is spontaneous, the risk is this much. If the labor is induced, the risk increases. Augmented, again increases. With elective repeat cesarean section, the risk is so less. Rupture risk, of course, it will be very less. Less than 0.02%. Okay. So these percentages, since they have been asked in previous examinations, please do have a look at them. Induction. If you happen to induce any lady with a previous scar, prefer mechanical induction methods over prostaglandin as they have got lower rupture risk. Most consistent sign of scar rupture is abnormal CTG. This again is a very important question which can be asked. Most consistent sign of scar rupture is fetal bradycardia, especially found in 66 to 76% of the cases. Next, regarding VBAC intrapartum care, Deliver in a unit where you can put her on continuous electronic fetal monitoring right from the onset of regular contractions. Plus, if in any case you need to shift her for cesarean section, there should be immediate C-section and transfusion access. You should be on the lookout for abnormal signs as you have already put her on continuous CTG. Wherever you find any bradycardia or abnormal CTG otherwise, you have to consider rupture in your mind. What can be the other signs? Scar pain, loss of station. Earlier on PV, you were feeling the station very well. Now it has gone up. Vaginal bleeding, hematuria, maternal tachycardia, or collapse. All these indicate towards rupture. Elective repeat cesarean section should, if you are doing elective repeat cesarean section, then schedule after 39 weeks. If labor starts earlier, proceed whenever she is in established labor. If you have to go for repeat cesarean. Surgical prophylaxis is the same as for cesarean sections, pre-incision cefuroxime and metronidazole. In antenatal period, avoid coamoxiclav because of concern of necrotizing enterocolitis. Now, one never and always point, never use prostaglandin in preference to mechanical methods for VBAC induction. Never ignore a new abnormal CTG on a scarred uterus. Always go for continuous electronic fetal monitoring in labor and counsel rupture risk, approximately 0.5% versus elective repeat cesarean section. Then comes shoulder dystocia, another very important topic, how to know about the risk factors and how to recognize at the earliest so that you can avoid any more morbidity and mortality. What is the definition? Any vaginal cephalic birth which needs additional maneuvers after the head delivers, or if it is not delivering despite gentle axial traction, then it is termed as shoulder dystocia. You must be aware of turtle sign, the the time interval of 60 seconds. So vaginal cephalic birth, which needs additional maneuvers after the delivery of head and even after gentle axial traction fails, is termed as shoulder dystocia. Incidence is approximately 0.6%. The risks are maternal PPH, 11%. Risks means these things can happen and the chances are more with shoulder dystocia. PPH in 11%, anal sphincter injury, obstetric anal sphincter injury in 3.8%, fetal brachial plexus injury in 2 to 16%, fractures, hypoxic ischemic encephalopathy, all, and fetal BPI being the most common cause of litigation. So all these are the risks, and these percentages are important because they have been asked earlier. So please have a look at them. Poorly predictable. You can't predict. Always it is not happening in diabetic and macrosomic babies only. So the positive prediction value is low. 48% occur in babies which are less than 4 kg. Hence, prediction models as such are not recommended. Risk factors, some of the risk factors which have been identified are pre-labor risk factors like previous shoulder dystocia, macrosomia more than 4.5 kg, diabetes, BMI more than 30, or induction of labor. Wherever these are present, you have to be on the lookout for shoulder dystocia. Or during labor, if the labor was prolonged or arrested at any point of time, oxytocin has been used, assisted birth, then also it is risk factor for shoulder dystocia. How to recognize? Wherever you find difficulty with face chin, means face and chin are not adequately out and turtleneck sign is found, restitution is failing and shoulders are failing to descend, there be cautious regarding development of shoulder dystocia. Pearl point, diabetic mothers have 2 to 4 times the SD risk of non-diabetics of the same birth weight. Recurrence rate is 10 times. So these are the pearl points of shoulder dystocia. Coming to the RCOG algorithm, what to do when you have already diagnosed. Helper is one mnemonic which is used. However, you have to be aware of the algorithm which is given in the RCOG, because it has got a sequence that what to do first, what to do next. The first and foremost thing which you will do is call for help. So announce for help, announce that this is shoulder dystocia, discourage her to push, bring her to the edge of table, and stop giving fundal pressure. Means never. Fundal pressure is never to be given. And ask her not to push further. First and foremost is the McRoberts maneuver, which has got 90% success. 90% success with McRoberts maneuver. Remember, you will ask the lady to hyperflex and abduct the hips onto abdomen. Second, what you will do, suprapubic pressure. Standing on the side, you will apply from side of fetal back, downward and lateral with gentle axial traction, along with McRoberts. Then, up till now, most of the women will deliver. Suppose if shoulder dystocia isn't relieved yet, then is the time you will start thinking about internal maneuvers. And for that, you have to give episiotomy. So after this first and second, then only you give episiotomy, only to gain internal access, not to relieve the obstruction, which is actually bony in this case. Here it is bony obstruction. So episiotomy alone won't help. Episiotomy will only help to gain internal access. This is important. You should know this. Next, what maneuvers you will use? Either of the two. It is often confusing that if both are given, then what we will do? Deliver posterior arm or do internal maneuvers, even Wood's corkscrew, reverse Wood corkscrew, Rubens. And then if again unsuccessful, then go for all force position or Gaskin's maneuver. Then again repeat all these. And last resort is clidotomy, symphysiotomy, Zavanelli, which is rarely performed. In Zavanelli, put the head back and go for a cesarean section. So this is the sequence in which you have to carry out all the maneuvers. If you look at the helper memoir aid, H stands for call for help, E stands for evaluate for episiotomy, L stands for legs, McRoberts, P stands for suprapubic pressure, E stands for enter for internal rotation maneuvers, R stands for remove posterior arm, that is delivery of posterior arm, and last R stands for roll to all force. This is in fact brought for teaching drills, hence important. Otherwise, mainly you have to remember this sequence. Next, another important emergency is cord prolapse. So cord, whenever it descends alongside or past the presenting part, wherever it is alongside, it is called as occult cord prolapse. Where it has gone past the presenting part, it is called cord prolapse, overt cord prolapse with ruptured membranes. The incidence here is 0.1 to 0.6% overall. With breach, however, the incidence is high. We all know that if there is breach presentation, often the cord tends to slip out. So the incidence with breach is more. Risk factors: unstable or transverse lie, high head, polyhydramnios, prematurity, multiparity, or we can say that 50% of them follow any obstetric intervention. Whenever you are doing anything, like with high head, you did an ARM, or you performed an ECV, or you put an intrauterine pressure catheter, you did something, then in 50% cases, following means 50% cord prolapse cases often follow any obstetric intervention. How you can avoid? Avoid ARM with a high or unengaged head, and prefer to admit any transverse lie from 37 to 38 weeks so that you don't miss out on cord prolapse. How you will diagnose? Suppose membranes ruptured and baby develops abnormal fetal heart rate. It may be in the form of bradycardia or variable or late decelerations. Then immediately you have to look for it. Go for a vaginal examination. If cord is palpable or visible, diagnose as cord prolapse. So a pearl point is any FHR abnormality immediately after rupture of membranes, exclude cord prolapse by vaginal examination. This always you have to remember. What about management? Immediately call for help as it's an emergency. Do not try to handle manually and do not try to replace it. Minimize handling, keep warm. What your aim is to manually elevate the presenting part so that pressure on the cord is relieved. Now, either you can do it through position or you can do it through bladder filling. First and foremost, preferable option is bladder filling. Fill bladder 500 to 750 ml empty before birth. Positioning. Now, when she is in community waiting to be transferred, then the preferred position is knee chest position. Knee chest position so that pressure on the cord is relieved. Presenting part gets elevated and pressure on the cord is relieved. But during transfer, while she is being taken in ambulance, this is during waiting. While she is being transferred, then left lateral head down or exaggerated Sims is in the preferred position during transfer. Okay. Why? Because if she will be in the knee chest position, then she might tend to fall. So during transfer in ambulance, exaggerated Sims position is preferable so that fall is prevented. Of course, it's a safer position during transfer. Also, you can consider tocolysis. Consider terbutaline 0.25 mg subcutaneous if persistent bradycardia while preparing theatre. And regarding birth, as soon as she arrives, suppose she was in community, midwife filled the bladder, presumed the appropriate positions, and when she reaches hospital, the first and foremost thing is look for FHR. If the FHR is abnormal, immediately shift her for category 1 cesarean section. The aim should be to deliver her within 30 minutes. If FHR is normal, then also you have to expedite delivery, but can be done under category 2, that is up to 75 minutes time can be allowed. If she is fully dilated and you seem the delivery is imminent, then you can apply forceps or ventouse if it looks safe. So what will be your techniques to relieve cord compression? Elevate presenting part, preferably through bladder filling or manually if possible. Knee chest position to keep gravity off the cord. Minimal cord handling to avoid vasospasm. Category 1 cesarean section if FHR is abnormal. Never attempt to push the cord back into the uterus. Handle the cord as little as possible. Now coming to another important topic, that is perineal trauma or OASI. Regarding classification and prevention, the incidence is overall 3%, 6% in primary and approximately 2% in multi. So the incidence is quite high in primary. Risk factors, forceps without episiotomy, odds ratio becomes high, 6.5. Nulliparity, birth weight more than 4 kg, shoulder dystocia, occipito-posterior position, prolonged second stage, Asian ethnicity, all these predispose the lady to developing OASI more. How you can prevent? Mediolateral episiotomy in instrumental births, 60 degrees. Warm compress, manual perineal protection. These are the tenets for prevention. Diagnosis, systematic examination, including digital rectal examination in every vaginal birth before and after suturing. So this is how you won't be able to miss. Next is the classification. Very, very important. 3A, especially the third one, since it is categorized, grade 3 is categorized into 3A, 3B, 3C degrees actually. So first degree is only when skin is involved. Second degree, when muscle is involved. Third degree, when this 50-degree external anal sphincter is torn. Less than 50 degree, it's 3A. If 50%, not degree, sorry, percent. Less than 50% external anal sphincter is torn, then it's 3A. If 50% or more of external anal sphincter is torn, it's 3B. If both external anal sphincter and internal anal sphincter are torn, then it's 3C. When anorectal mucosa is involved, it becomes 4th degree. And one another entity is buttonhole. Where the rectal mucosa is torn but the sphincter is intact, it's separate, called as buttonhole tear. The pearl point here is, if we give forceps plus episiotomy, it markedly lowers OASI versus forceps alone. So this is a classic SPA contrast. Regarding repair, aftercare, and future birth, always wherever you are taking up a patient with OASI for repair, prefer to do that in theater, under regional or general anesthesia, under good light, trained operator, and rectal examination should always be done after repair. Internal anal sphincter, repair separately. Interrupted or mattress suture, no overlap. External anal sphincter, when there is full thickness, then overlap or end to end. Where there is partial thickness, means 3A plus some 3B, end to end only. Sutures, what to use? Again, this is very important SBA question. Wherever mucosa, you use 3-0 polygalactin. Sphincter, 3-0 PDS or 2-0 polygalactin. Avoid figure of 8 because you don't have to do it too tight, and try to bury the knots. So these principles you have to remember, the principle and the types of sutures. Regarding post-op, always broad spectrum antibiotics are must. See, routine episiotomy as such might not require antibiotics, but OASI repair and after forceps, you have to give antibiotics. Plus laxatives also. No bulking agents, prefer not to give bulking agents. Physiotherapy and review after 6 to 12 weeks is required. Now regarding future, 60 to 80% remain asymptomatic at 12 months. Again, important SBA question. Recurrence is 5 to 7%. Now, usually you can allow vaginal birth if she has become asymptomatic and she is doing well. But if she remains symptomatic, number 1, or if her endoanal ultrasound manometry shows abnormality, number 2, then if either or both is there, then you have to go for elective elective cesarean section in the next delivery. Now, never repair OASIS outside theater without senior input. Use figure of 8 sutures. Never give routine bulking agents. Use just laxatives, and always prefer to perform a digital rectal examination before and after repair so that you don't miss out on any OASI. Now let's have a look at cesarean section urgency categories. Category 1, when there is immediate threat to life, maybe that of fetus or maybe that of mother, you have to carry out ASAP. 30 minutes is the key word here, key timing here. Examples include abruption. I always say, remember arc, abruption, rupture, and cord prolapse. Then prolonged bradycardia, or wherever the patient is bleeding and you think that she can become hypovolemic and there might be threat to life, there also take her up for category 1 cesarean section. Wherever there is compromise which is not immediately life-threatening, there the key time is 75 minutes. Like, for example, suspicious CTG not responding to conservative measures or fetal scalp stimulation, pathological CTG, failed instrumental delivery, breach in labor, there you have to do quickly, but not there is no life-threatening kind of thing. Then it is category 2. Category 3 are those which need early delivery, no doubt, but as such, there is no element of any compromise, and time as such is not a very limiting factor. Like, for example, failed IOL or spontaneous rupture of membranes awaiting cesarean section, these all can be taken as category 3 cesarean. And category 4 are elective ones, for which you can choose a suitable time, like previa, breach, that is malpresentation, transverse, previous classical CS or any CS on maternal request. So remember the urgency. It's based on urgency, not difficulty. So immediate 30 minutes, urgent 75 minutes, early planned within hours, and elective scheduled is category 4. Prom booked for elective repeat cesarean section with normal CTG is category 3. Okay. Now let's come to our final R, that is SBA and recall drill. So this will get a bit interesting. We will be giving you recall SBAs July 25 and prior with full reasoning along with CTG classification practice, recall EMQs, especially focused on preterm prevention, then master recall grid along with high yield traps, and at last, never versus always summary. Now let's have a look at questions. Everyone get up. So a multiparous woman in established labor, CTG baseline 145, variability 8, variable decelerations with no concerning features means again white, 4 contractions in 10 minutes. How is this CTG categorized? Now, if we start categorizing one by one, CTG baseline, this seems to be all right, white. Variability again seems to be all right, white. Variable decelerations with no concerning features again seems to be right, white. And 4 contractions in 10 minutes, white. So it most probably is a normal CTG as all 4 features are white. Suspicious pathological acute bradycardia is not there, sinusoidal no. So variable decelerations without concerning features, remember, are a white feature and in fact are common. Why? It happens because of, remember, cord compression. Early because of head compression, late because of uteroplacental insufficiency. Let's come to next question. A 31-year primee at 41 weeks, spontaneous labor, 24 hours, since 24 hours reduced fetal movements plus fresh vaginal bleeding. Now cervix is 5 centimeter. Heavy blood stained liquor, CTG 60 minutes. Baseline 140, absent variability, no accelerations and decelerations. What is the most appropriate management? Now here fresh vaginal bleeding is one thing which should raise our ears. She is 41 weeks, labor is spontaneous. Since 24 hours, she was having reduced fetal movements. Cervix is 5 centimeter and heavy blood-stained liquor. Heavy blood-stained liquor, and on that, variability is absent. Although there are no accelerations, although there are no decelerations, but absent variability for 60 minutes. So you all must remember is what? Absent variability, reduced variability less than 5 for more than 50 minutes is red feature. So here we have to be on the lookout for options. Option of category 1 cesarean section. Why? Because absent variability more than 50 minutes with no accelerations means the CTG is pathological. Reduced fetal movements with heavy blood-stained liquor. Our most probable suspicion is abruption or severe hypoxia. She is first stage, just 5 centimeter. Vaginal birth doesn't seem to be imminent. So immediate delivery is valid here. FBS is contraindicated. Category 2 will be too slow and head not low. So cervix only 5 centimeters. So other options are not feasible. The best option here would be category 1 cesarean section. Why? Because there is threat to life of the fetus. Next, para 2, prior vaginal birth, then elective CS, induced at 41 weeks, 4 days. Means 1 vaginal birth and 1 cesarean section she has already undergone. She is induced with ARM and oxytocin and epidural given. 3 hours later, she reports of sudden severe constant abdominal pain. On CTG, you get decelerations plus difficulty detecting the fetal heart. Cervix regressed, vertex no longer palpable, previous cesarean, all these factors, blood-stained liquor with clots point towards rupture uterus. So here again, rupture uterus, you will never leave for anything else but category 1 cesarean section. So why classic? This is classic uterine rupture presentation with sudden pain, CTG deterioration, loss of station, bleeding, and hard to hear fetal heart. It's an obstetric emergency, immediate delivery, and prepare for laparotomy. If laparotomy is given in the option, you can choose that also. Loss of station plus pain in a V back. It is rupture until proven otherwise. So don't waste time on conservative measures. Then a 33-year nulliparous woman at 41 weeks 5 days induced with dinoprostone 10 mg pessary. A few hours later, she has 7 to 8 contractions in 10 minutes. Now here we get concerned because it is more than 4. CTG shows one amber feature, that is hyperstimulation. She wants to continue in labor. Most appropriate next step. So first we will look for an option that is remove pessary, but that is not there. So next we will look for an option like tocolysis. So tocolysis here, this one will be the preferred option. Terbutaline 500 microgram IV slowly over 1 minute. Why? Because uterine hyperstimulation is clear-cut diagnosed here. So if remove the prostaglandin and give tocolysis is not an option, you will choose an option closest to that. Here IV preferred for rapid action in acute hyperstimulation. IV preferred for rapid action. IM is slower, hence not ideal in acute hyperstimulation. So this is 2025 recall answer. Next, a Gravida 3 para 2 at 39 weeks with an epidural contracting 4 in 10 minutes was 5 centimeter 1 hour ago. Spontaneous rupture of membranes occurred 20 minutes back. Since then, the CTG shows variable decelerations. What is your first action? Now here, since after rupture of membranes, you started having suspicious or concerning CTG, so the first thing we will do is carry out a vaginal examination. Okay, so we will look for that in our options. Perform a vaginal examination should be our preferred choice. Why? Because we will rule out cord prolapse. New CTG change immediately after spontaneous rupture of membranes. We need to suspect cord prolapse and rule it out. Vaginal examination is the only way to exclude or confirm it and assess the dilatation and descent also. If, like, for example, delivery is imminent, we might choose expedition of delivery after cord prolapse. So, but the first thing what we will do, of course, vaginal examination to guide the urgency and mode of birth. New CTG abnormality, remember the pearl point. New CTG abnormality after membrane rupture, go for vaginal examination first to exclude cord prolapse. Next question. After a home stretch and sweep, membranes ruptured and the cord was palpated below the vertex. On arrival, vaginal examination confirms cord prolapse. Cervix is 2 centimeter and fetal heart rate is good. Now, cord prolapse with normal FHR demands category 2 cesarean section. So we will look for a similar option. What we will do next? After a home stretch and sweep, and now she has arrived. So confirm fetal heart with urgent ultrasound. Already confirmed fetal heart is good. Apply a fetal scalp electrode. No role of that. Elevate the presenting part and prepare for category 1 or 2 CS. Seems to be the closest option. Commence oxytocin by position supine and await full dilatation. No. So the best option here appears C. That is, elevate the presenting part and prepare for category 2 cesarean section since vaginal birth is not imminent. Manually elevate presenting part to relieve cord compression. Knee chest left lateral, consider bladder filling. Do not replace the cord. Cord prolapse plus low cervical dilatation. So elevate the presenting part and go for category 1 or 2 cesarean section depending on the fetal heart rate. Next, Mrs. R, 37 weeks, 5 days, booked for elective repeat cesarean section at 39 weeks. Prior emergency cesarean section plus major PPH was there in her. So now this time she has booked for elective repeat cesarean section. She presents with spontaneous rupture of membranes, clear liquor, one contraction in 10 minutes, cervix closed and CTG normal. Most appropriate management. Now she is 37 weeks, 5 days and she has booked for elective repeat cesarean section at 39 weeks. And now her membranes have ruptured. The liquor is clear and she has gone into labor and she was to be taken up for elective repeat cesarean section. So now what you will do? Will you do expectant management or induction of labor? She was to be taken up for cesarean section. So no, now we can take her up for category 3 cesarean section. The scenario which I showed to you earlier also. Here delivery is needed, no doubt, but it's not that we need to do within 75 minutes or so. We need to do early, but there is no element of compromise. Hence, it is category 3 cesarean section. So wherever you have to take her up for cesarean now, but not within 75 minutes, without any element of compromise, there you will choose category 3 cesarean section. For example, she was booked for elective cesarean section, but she has gone into labor. In those cases especially, category 3 is the correct answer. So Pearl points: 1, where immediate threat to life is there. 2, there is compromise, not immediately life-threatening. 3rd, where she needs early delivery without any element of compromise. And 4th is elective. Hope these categories are clear. A gravida to para 1 at 32 to 33 weeks with confirmed PPROM, that is pre-labor premature rupture of membranes, has healing genital herpetic lesions. Recurrent. The similar she had in last pregnancy also. She is afebrile, stable, CTG is reassuring. What is the most appropriate management? Now here, since she is PPROM, she is 32 to 33 weeks, has recurrent genital herpetic lesions but resolving. So here most probably, since she is less than 34 weeks, we can opt for conservative management. Okay. So immediate CS, of course, not required. Oral acyclovir and immediate induction at 32 to 33 weeks, not required. Yes, this can be considered antenatal corticosteroids plus erythromycin with expectant management. Tocolysis, not to be preferred in PPROM. IV antibiotics and delivery within 24 hours, not required. So the best option here seems to be C, steroids, erythromycin and expectant management. According to the guideline also, PPROM less than 34 weeks, prefer expectant management through steroids to reduce the incidence of these complications, erythromycin for 10 days, and expectant management if she is stable. If the HSV is recurrent with healing lesions, it's not an indication for immediate delivery as such. We can give suppressive acyclovir from 36 weeks and deliver at 37 weeks if uncomplicated. So the message is that at less than 34 weeks PPROM with recurrent herpetic lesions, we can go for expectant management. Next, a woman in early labor, breech, cervix 6 centimeter. Gentle vaginal examination reveals cord pulsations felt behind intact membranes. That means she is breech with cord presentation in labor. CTG is good, prepared for theater, but all OTs are occupied. Best holding measure for now will be Of course, not emergency CS because OTs are occupied. Tocolysis, fill the bladder, or manually elevate the presenting part. So the best option here would be to fill the bladder. This is the preferred option to elevate the presenting part instead of manual elevation. So cord presentation with theater unavailable, we need to relieve the pressure of the cord. So the best method here should be to fill the bladder, because filling the bladder elevates the presenting part and relieves pressure on the cord with lower risk as compared to manually elevating the presenting part. Tocolysis can be added while awaiting CS, but the best option will be to fill the bladder. Yes, cord presentation with intact membranes and theater delay, fill the bladder plus minus tocolysis. Contrast it with prolapse. Here it is cord presentation. In contrast with prolapse, elevate the presenting part plus category 1 CS. Here fill the bladder plus minus tocolysis can be considered. So this is the contrasting point which we have to keep in mind. Tocolysis is adjunct, not the single best holding measure. B and E options, that is knee chest position and elevating the presenting part, are more useful in cord prolapse where the membranes are ruptured. But here, since the membranes are intact, hence the best option is filling the bladder. This one is important. Please keep in mind. Next, a 30-year nulliparous woman has pushed for 3 hours with an epidural. Now here she has exceeded the time limit. Within 3 hours, the birth has to be achieved. She has already pushed for 3 hours. She is exhausted, must be. CTG now shows recurrent late decelerations. Vaginal examination shows fully dilated, head +2, occipito anterior. So the most appropriate management should be. Now here she has already exceeded the limit. We need to assess her for instrumental vaginal birth if feasible. So let's look at the options. Continue pushing, not at all. Oxytocin augmentation, no. Assisted vaginal birth seems to be the best option here because there seems not to be any contraindication. Head is +2, occipito anterior. So the best option here seems to be AVB, that is instrumental vaginal birth or assisted vaginal birth. Outlet or low cavity, it will be suitable for assisted. Head is +2, so low cavity, suitable for assisted birth. And indication is also there. Already she has crossed the limit, beyond the limit. Next, a primary gravida treated with acyclovir for a primary episode of genital herpes at 36 weeks opts for vaginal delivery. Now, primary opting for vaginal delivery, always keep in mind, primary herpes vaginal delivery risk is very high. So what's the risk of neonatal herpes if she delivers vaginally? It's clearly 41%. This number is very, very important, has been repeatedly asked. So please remember, primary HSV in the 3rd trimester carries a very high neonatal transmission risk if vaginal birth ensues by any chance, by her choice, and the risk is 41%. C-section is therefore recommended for primary HSV within 6 weeks, especially if primary episode is occurring within 6 weeks of delivery. And even if any time it is occurring in 3rd trimester, counsel her to undergo a cesarean section. Recurrent HSV carries a far lower risk, approximately 0 to 3%. Then a 26-year gravida 4 para 3 at 38 weeks. Uncomplicated, non-tender uterus, regular FHS. Presentation scan confirms breech, most appropriate immediate management. Wherever any multi or primary gravida coming with breech, we start looking for ECV in our options. So here we have got ECV. No need to give all these. Most appropriate immediate management is offer ECV. She is breech, she is term, means in multigravida we can offer from 37 weeks onwards, in primary we can offer from 36 weeks onwards. So we can offer ECV now unless any contraindication is there. Always in any scenario, please look at the whole scenario for any contraindications also. There might be some very small word written which we might overlook. So read the scenario very carefully. There is no contraindication here. Hence, we can safely proceed for offering ECV. Success rate here in multipara, so success rate will be 60%. If declined by the patient or fails, then counsel for planned CS versus vaginal breech birth. Term breech, Pearl Point, first offer ECV. Tocolysis alone is not the answer. Now coming to match, or we can say recall EMQs, match the management. Now these are the options: serial cervical length surveillance, vaginal progesterone, history indicated cerclage or ultrasound indicated cerclage, combined cerclage plus progesterone, or twin pregnancy surveillance. Let's have a look. Prior preterm birth, 32 weeks. That means she has had a mid-trimester loss between 16 to 34 weeks. This is. Now she is 18 weeks and cervix is found to be short. That is 20 mm. Although she is asymptomatic. So this lady is fulfilling the criteria for ultrasound indicated cerclage. One preterm birth is there. So history indicated cerclage won't be there. Short cervix is there. So in fact, if we see the NICE guideline, then progesterone can also be given. But the better option, if we look according to GTG, here she is a high-risk woman, and since on ultrasound scanning she is found to have short cervix, better option is to choose ultrasound indicated cerclage. Next, prior 18 weeks loss, again now 16 weeks, cervix 32 mm, and there are no symptoms. So since she is high risk, she has had mid-trimester loss. So now we should continue cervical length surveillance. Since now cervix is okay, but we should continue keeping her in surveillance. So most probable option is serial cervical length surveillance. Third, prior mid-trimester loss, now 18 weeks, cervix short. Here again, ultrasound indicated cerclage should be the preferred option because it is quite similar to first question. Primigravida, incidental cervix found to be short at 20 weeks. There is no history as such. So here actually according to NICE guideline, we can consider prophylactic vaginal progesterone. Previous LEDs, twin pregnancy, 16 weeks, normal cervix, no prior preterm birth. Now here, only twin pregnancy surveillance needs to be carried out because we won't carry out cerclage anyhow. In multiple pregnancy, we avoid cerclage. So here, according to us, most probable option is ultrasound indicated cerclage for first and third. Second should be A, serial cervical length surveillance only because she is at risk, but for now the cervix is okay. Incidental finding of short cervix in primigravida, we can consider vaginal progesterone, and in twins, we should not prefer cerclage, just twin pregnancy surveillance is okay. So let's have a look at the answer. First D, yes, ultrasound indicated cerclage. History of loss, but cervix is fine, so continue serial cervical length surveillance. Prior loss is there, plus short cervix is there, so ultrasound indicated cerclage. Low risk means primigravida, having incidental short cervix finding. No history as such, so we can consider vaginal progesterone, not cerclage. In twins, continue twin pregnancy surveillance. Although you can continue surveillance in preterm clinic if given because she was having LEDs. So she is intermediate risk according to GTG. But as such, you will never take her up for cerclage because women with a history of spontaneous second trimester loss or preterm birth who have not undergone a history indicated cerclage may be offered serial sonographic surveillance. as those who experience cervical shortening may benefit from ultrasound indicated cerclage. This is the explanation for the above questions. Next, choose the management. Nullipara, pushed 3 hours with epidural, exhausted. Again, she has crossed the limits. Recurrent late decelerations, fully dilated, +2, occipito anterior. What should be the preferred option? We should take her up for, since there is no as such contraindication to assisted vaginal birth. So ventouse or assisted vaginal birth should be the preferred answer. Primi gravida, fetal bradycardia more than 6 minutes in second stage, head +2, occipito anterior, meconium liquor. Now, fetal bradycardia, head +2, occipito anterior, meconium liquor, again is an indication for assisted vaginal birth. Here also no contraindications, and since fetus seems to be compromised, so we won't look for whether she has pushed for 1 hour, 2 hour or 3 hours. Since fetus is compromised, we need to expedite the delivery. Hence again, ventouse or assisted vaginal birth should be the answer. Then low risk nulliparous. She was 7 centimeter 1 hour ago on epidural. CTG is now sinusoidal for 30 minutes and baseline 155. Now sinusoidal anytime demands urgent LSCS because it's a pathological, not only pathological, but indicative of fetal compromise. So answers for the first two, we wanted instrumental vaginal birth, and for the second, category 1 cesarean section. Because in sinusoidal trace, somehow signifies suspected fetal anemia. And for these two, we have to expedite delivery. So some high yield traps. CTG classification, we should all be well aware. If normal, all white, then it will be normal CTG. 1 amber will be suspicious. 1 red or 2 or more amber will be pathological. Decelerations, any late deceleration is red. Any duration, any type, it's always red. Sinusoidal is always red. Variable without any concerning features is white. Acute bradycardia, deceleration for more than 3 minutes requires urgent review. If it is persisting beyond 9 minutes, deliver. First stage delay, when you will suspect delay, less than 2 centimeter in 4 hours, then reassess in 2 hours, do amniotomy, reassess in 2 hours. See, if less than 2 centimeter in 4 hours, suspect delay. Okay, this is suspect delay. Reassess in 2 hours. If still the progress is low, then at this time you have to diagnose delay. Amniotomy you did, reassessed again in 2 hours. This is important. After amniotomy, you reassess in 2 hours. Give her oxytocin. If still the progress is not good, you have to reassess after 4 hours after oxytocin. If still the progress is not good, take her up for, consider her for cesarean section. So you need to know when to suspect delay and when to diagnose delay. Second stage delay, suspect when. See, in this one thing again remember that passive second stage. What is passive? Epidural will prolong the passive second stage. In nullipara by 1 hour. In multipara, maximum of 1 hour can be allowed. In nullipara, maximum of 2 hours of passive stage can be allowed if she is on epidural. Now, when you call it suspect and when you call diagnose delay, when she has started pushing. Once she starts pushing, reassess nullipara after 1 hour. If progress is not good, suspect delay. Reassess multipara after 30 minutes of active pushing. If progress not good, suspect delay. Then reassess nullipara again after 1 hour. If progress not good, diagnose delay. Reassess multipara again after 30 minutes. If total after 1 hour of pushing, progress is not good, diagnose delay. Okay. So suspect delay in nullipara after 1 hour, diagnose delay in nullipara after 2 hours. Suspect delay in multipara after 30 minutes. Diagnose delay in multipara after 1 hour of total pushing. Epidural, remember, prolongs only passive stage. FBS not recommended, forget it. Facial O2 may harm. No amnio infusion recommended. IV fluids give only if hypotensive or septic. In conservative measures we are talking about. PPROM, erythromycin you have to give for 10 days or till the time the baby delivers, whichever comes sooner. Coamoxiclav is contraindicated. Tocolysis not recommended in PPROM. Preterm drugs, treat if she's less than 30 weeks immediately without any testing. More than 30 weeks, test. This is very important. Remember, test through cervical length if less than 15 mm, treat, or fetal fibronectin if more than 50, treat. Treat through steroids, tocolysis. Tocolysis you can give to buy time for transfer or steroid coverage, and Maxulf if delivery is imminent within 24 hours for neuroprotection. Offer at less than 34 weeks, offer at less than 30 weeks. Hyperstimulation, if any you encounter, remove prostaglandin or stop oxytocin. If it doesn't work, give terbutaline 500 microgram IV according to this recall question for fast action. Otherwise, in guideline, it's given subcutaneous 250 microgram. When you will suspect rupture, if any lady is undergoing VBAC and there is loss of station along with pain, hematuria. Okay, and the commonest sign this, remember, is abnormal CTG. What you have to do? Immediately take her up for category 1 cesarean section, or you have to look for laparotomy in your options. Okay. Cord prolapse. If cord prolapse is there, elevate. First of all, check whether heart rate is okay or not. If heart rate is okay, you can do category 2 cesarean section. Otherwise, mostly category 1 cesarean section. Meanwhile, while you are waiting, elevate presenting part through knee chest position while they are waiting transfer. Exaggerated SIMS during transfer. Don't replace the cord. Manually handle to a minimum. Then some never versus always points. Never give routine facial oxygen for an abnormal CTG. It may harm the baby. Never give IV fluids for CTG abnormality unless she is hypotensive or unless she is septic. Don't give empirically to all. That this is conservative measure, so I'll start IV fluids for all. No. Rely on FBS. No longer recommended. Don't rely. Never use amoxiclav for PPROM because of risk of necrotizing enterocolitis. Never use typical words like typical or atypical to describe the decelerations. Now decelerations are just early, variable, late, concerning characteristics in decelerations. Now W pattern and all are gone. Loss of previously present shouldering, slow or late return to baseline, reduced variability within, prolonged decelerations, they are concerning characteristics. Never do a digital examination in suspected PPROM or placenta previa. Never use ergometrine where there is any cardiac or hypertensive risk. And never delay delivery in VBAC where you find these findings, loss of station or pain. Then always read the CTG with the whole clinical picture plus risk factors. Always offer intermittent auscultation to low-risk women. Offer intermittent auscultation to low-risk women, and always CTG offer when risk factors are present. And yes, if on intermittent auscultation you encounter any concerning features like rise by more than 20 beats per minute than before or any deceleration, then frequently, intermittently auscultate more frequently. If still concerns are confirmed, transfer to obstetric-led unit for CTG. Exclude acute events like cord prolapse, abruption, or rupture for any pathological trace. Deliver by 9 minutes if acute bradycardia persists. Give erythromycin for PPROM. Steroids plus Maxulf for preterm birth. We already know the gestational age when you have to immediately treat, that is less than 30 weeks. Hyperstimulation, first thing you will do is remove agent wherever you find 5 or more contractions in 10 minutes. 5 is also bad, okay? Up till 4 is okay. 5 or more contractions in 10 minutes. Try to remove the inducing agent, plus minus add terbutaline. Get fresh eyes hourly review for women on CTG. Fresh eyes will remove the bias and will reduce the rate of interventions and will avoid missing out on any interventions as well. Few questions again. Full dilatation, multiparous, station 0, direct occipito anterior, effective epidural. All right. So full dilatation, multiparous, station is 0 here. Direct occipito anterior, effective epidural, CTG is now pathological, no acute event. What is the most appropriate action here? Now here we see that station is 0. So it will come to our mind that this is mid cavity, but she is multiparous. All the things are fine. So we need to expedite the delivery. Since other features appear okay and the chances of success may be high because she is multiparous also, so we can do attempt an instrumental birth in the room as the criteria are met. CS at full dilatation with a deliverable head is more morbid, hence try to do instrumental birth. Full dilatation 2 hours, occipito posterior, station is +1, 2/5 palpable. Now this is something which contraindicates instrumental birth along with caput plus and molding plus and suspicious CTG. Here we'll have to shift her for cesarean section, and you will also need to search for an option that says that might be you need to reassess in the OT to look whether she has become eligible for assisted vaginal birth or not. So depending on the type of options which you are getting, you will choose your answer. Might be cesarean section, might be reassess for trial of instrumental birth in theatre. Here mid cavity is there and head is 2/5 palpable, so there is high failure risk. So if she becomes also eligible for instrumental birth, immediate recourse to CS is necessary, hence it should be done in theatre. Ventus for prolonged second stage after 3 pulls with correct placement and good effort, no descent. CTG is pathological. Then try to shift her for cesarean section. Abandon and proceed to cesarean. Sequential instrumental delivery is risky and markedly increases neonatal trauma. On top of that, CTG is also pathological, so don't attempt. Station +2, occipito anterior, head 1/5 palpable, minimal caput, effective epidural, experienced operator. So this nothing contraindicates. So we can do a low cavity non-rotational forceps. We can apply in the room. Head is well below spines, deliverable and no rotation needed since it is occipito anterior. So low cavity non-rotational in room we can do. Next, decision for category 1 cesarean section for sustained bradycardia after cord prolapse. What should be decision to delivery interval? Now category 1, wherever it is, always remember it's 30 minutes. For category 2, it's 75 minutes. Okay, it's an audit guide, not a fixed cutoff. 75 minutes is for category 2 and 30 minutes is for category 1. One previous cesarean for breech, no contraindication, placenta low, not low, and she wishes to avoid CS. Recommendation is planned VBAC, she can undergo. Success rate is 72 to 75%. Rupture rate will be 0.5%. The delivery should take place at obstetric unit with continuous electronic fetal heart rate monitoring. This is the prerequisite. Previous classical cesarean section, uncomplicated pregnancy. We can't allow to deliver vaginally. she should always be taken up for cesarean section because of high risk of rupture. Planned cesarean before the onset of labor at any cost. VBAC is contraindicated here because of high pre-labor rupture risk. Last, category 1 CS for bradycardia. At laparotomy, hemoperitoneum with fetus extruding through a uterine defect was found. Prior cesarean, constant pain. Diagnosis most probably here is, it's in front of you, uterine rupture. Complete rupture as fetus is extruding through the wall defect. Regarding intrapartum emergencies, 6 centimeter spontaneous rupture of membrane with high presenting part, prolonged deceleration to 60 beats per minute. Now, she is 6 centimeter and membranes are ruptured, presenting part is high. Pulsatile cord felt below the presenting part. Immediate measure while preparing theatre. So, we all know, since membranes are ruptured and theatre, while you are preparing, what you have to do, you have to elevate the presenting part. So, you can do it through knee chest position. If membranes were intact, you can do it by filling the bladder. If membranes are ruptured, you have to look at the option, elevate the presenting part plus knee chest position. However, never choose options like these, that handling the cord, replacing the cord. You have to choose options like category 1 cesarean, and while she is being prepared, you have to elevate the presenting part, knee chest position. Head delivers, retracts tightly, immediately puts our mind towards shoulder dystocia. No restitution, shoulders fail to deliver, help summoned, no maneuvers yet. First maneuver always will be Mac-Roberts with success rate of 90%. First line, fundal pressure is contraindicated. Next, shoulder pain, Mac-Roberts and suprapubic failed over 2 contractions. Now episiotomy has been done for access. Yes. Wherever these 2 have been done, next what is to be done if they ask? Then next is to be done is episiotomy. If episiotomy also has been done, then what next? Of course, we look either for internal rotation or delivery of posterior arm. If both are given, prefer this option, deliver the posterior arm. It is most effective internal maneuver, or internal rotation maneuvers also you can choose. Para 3, post-delivery profound shock plus bradycardia out of proportion to loss. Wherever this term you find that bradycardia is out of proportion to loss, try to think about uterine inversion. Fundal mass at introitus, fundus not palpable. Management. So here the correct answer most probably is acute uterine inversion management. So here immediate manual replacement of the uterus plus resuscitation. Manual replacement of the uterus, O'Sullivan method, hydrostatic replacement, all such, you have to look for these options. Johnson maneuver, O'Sullivan's. Then replace before the ring tightens. Our aim is to replace before the obstruction ring appears. So the best option here is immediate manual replacement of the uterus along with resuscitation simultaneously. Last one, match each scenario to the single best option. So here the options have been given: previa abruption, vasa previa, uterine rupture, uterine inversion, cord prolapse. All these are sort of acute intrapartum event options. Let's have a look at the scenarios. APH with tender uterus plus sinusoidal trace, placenta is not low. Sinusoidal means bleeding. So most probable option here is abruption. So she needs to be taken up for category 1 cesarean section. APH with tender uterus and not low-lying placenta already brings abruption in our mind. Sinusoidal trace confirms it. Previous CS, immediately, if previous CS is there and acute intrapartum event type options are there, then rupture is on our mind first. If she's on oxytocin, acute bradycardia, fresh bleeding, rising presenting part, and maternal tachycardia. These confirm uterine rupture. Amniotomy with a subcentoriate lobe, which is a risk factor for vasa previa. Let's see. Blood-stained liquor, tachycardia, loss of variability, and bradycardia. Now, in vasa previa, it's very essential to deliver immediately. In fact, elective delivery, if diagnosis has been made during antenatal period, is very much indicated. So, this looks vasa previa. Brisk PPH, see, tachycardia, loss of variability, immediately bradycardia. Such sudden and quick deterioration is seen in vasa previa. Brisk PPH after forceps, uterus is well contracted. PPH with uterus well contracted, forceps on the background of forceps delivery brings us to traumatic PPH, genital tract trauma. Placenta complete, that is retained placenta, is also not there. Tone trauma, tissue thrombin. So tone is not there, tissue is not there. Normal clotting means thrombin is also okay. So the remaining thing is trauma. Spontaneous rupture of membranes, high head, prolonged deceleration, pulsatile loop felt below the presenting part. Most probably takes us towards the diagnosis of cord prolapse. So this is regarding acute intrapartum events. So hope the questions were helpful. Hope the slides were helpful. So this brings us to the end of our presentation. Today we were able to finish early. So hope all of you enjoyed the session. All of the questions and all, please put, we will be taking up later. And do post in group and do post the feedbacks and be in touch. We all will be resuming with new module from tomorrow. So Anusha, can we finish off the session?
Yeah, sure, ma'am.
Yeah. So hope you all guys enjoyed the session. Please, the doubts we all will be taking in the chat box. You all can type your doubts in the chat box. We will be addressing them all. Don't worry. And all the very best for your preparation. Bye-bye and all the very best. Bye-bye.